Well, good morning, everyone, and thank you for coming to this presentation. Thank you to Rebecca for hosting and facilitating this. Like she said, my name is Dr. Danielle Klein. I am a physical therapist in the Hastings, Nebraska area, which, excuse me, in South Central Nebraska. It's a town of about 25,000. It's a pretty rural area of Nebraska that I live in. And I recently started working at the local hospital in December. Several reasons why I took that job, but part of it was to start an acute care OB program. It's just an area that I feel is significantly underserved. And so today I'm going to be presenting about acute care PT and OT rehabilitation, specifically after cesarean sections. I chose to focus on C-section recovery because I myself have had 4 C-sections. And although I feel like I was given very good care for what the medical staff's current level of knowledge was, I know that there are ways that we can improve postpartum care for all mothers, but specifically those that have had cesarean sections. A quote from Rebecca from the Enhanced Recovery After Delivery course that really stuck with me was, quote, "C-sections were the #1 reason for inpatient stays in 2018, yet we insist that knee replacements require our attention from at least a PT-OT perspective at least 2 times per day. And yet it is okay to send someone home after a major abdominal surgery without any support as to how they can enhance their recovery." End quote. And I just, kind of agree with that. I don't feel it's right. Like, it's, having had 4 myself, it's a major abdominal surgery. I was given very little instruction from my physicians. I think because they knew I was a PT that specialized in this, I don't know if that affected how much instruction they gave me. They're like, "Oh, she knows, she can just figure it out." But I'm assuming that this is all women that get very little education. So my goal for creating an acute care obstetric PT-OT program is to help maximize patients' function and further improve overall satisfaction and quality of life after delivery. There are some different options for achieving this. For example, seeing patients while still in the hospital postpartum, or seeing them via home health within ideally the first 2 weeks postpartum. And I will cover more specifics about both of these later in the presentation. So some general facts about cesarean sections. The overall cesarean section delivery rate in the United States was 32.1% in 2001, according to the CDC. Cesarean section procedures can be performed for a variety of reasons. They can be scheduled, such as a repeat C-section, the baby's in an unusual position or breech, for example, which was the reason why I had to have my first one. The mother is carrying multiples, or just the mom's choice. They can also be emergent, such as when labor isn't progressing normally, the baby is in distress, or there is an issue with the placental or umbilical cord. Risks to the mother from a cesarean section include infection, blood loss, reactions to anesthesia, blood clots, surgical injury, such as to the bowel or bladder, increased risks during future pregnancies. Cesarean section complications also include a 6 to 14 times increased risk of unexpected hysterectomy, a 3.8 times increased risk of pulmonary embolism, a 5.8 times increased risk of stroke, a 5 times higher risk of postpartum infection, and a 12.3% rate of chronic pain at 10 months after C-section. And I feel like all of these risks are ways that PTs and OTs, we address these anyways in the hospital. So why not address them also for cesarean sections? So the role of acute care therapy while still in the hospital. Things that I'm going to cover include optimizing medical stability, monitoring and educating on appropriate activity tolerance, assisting with pain management, educating moms on self and newborn care, and mental and emotional patient support. So going back to optimizing medical stability, we can assess response to activity, such as assessing, heart rate, blood pressure, oxygen saturation, shortness of breath, headache, fatigue, swelling, and pain. We can do this during, while the patient's performing stairs, just regular ambulation, self or infant care, such as like taking a shower, all things that they're going to have to perform as soon as they go home. And we can screen for complications such as blood clots, preeclampsia, and their ability to complete these activities with or without pain, as well as their ability just to go home. If you think of like a total knee, for example, a lot of them have to be cleared by therapy to do stairs before they can go home. So why not do the same thing for a cesarean section? Um, all right, so monitoring and educating on appropriate activity tolerance. I realize that after a major abdominal surgery, there does need to be some resting, but also some movement involved. And so, educating them on appropriate levels of activity. This can look like the first day, just taking a walk around the room, and then maybe progressing to the second day, walking in the hallways. And we can provide education to moms on how they can monitor their symptoms to know that they're getting an appropriate level of activity. So monitoring for negative symptoms such as pain, specifically at their incision site or back, pelvic floor symptoms such as incontinence or like heaviness in their pelvic floor, shortness of breath, again, things like that. We can also help with assistive device prescription if they're having a significant amount of pain and maybe they need a walker still or something like that when they go home. Speaking of assisting with pain management, we can, help provide education on timing of pain medications based on when they'll have an upcoming activity. So taking pain meds maybe 30 to 60 minutes before planning to go on a walk or planning to take a shower. Also using breathing as helping with pain management. We hopefully all know that breathing can help manage pain levels by increasing the parasympathetic nervous system and decreasing the sympathetic nervous system. So another big thing is we can educate moms on self and newborn care, such as how to care for themselves, like incision management, getting in and out of bed or making position changes, performing stairs in an optimal way that's going to help with their pain management. It's going to minimize risk of issues with their incision, and things like that. Newborn care, how to lift their baby, how to use proper mechanics like not bending at the back too much or using their breath to help support their movements and not aggravating that incision. Breastfeeding positions that can minimize risk of increased neck, wrist, back pain, and improve C-section scar healing. So another way that we can help moms after C-section is to address mental and emotional patient support. I feel like there's a big stigma around cesarean sections that they aren't, quote, natural, or that the mom didn't, actually deliver the baby. And I feel that this is really harmful to a mom's mindset. I know that when I was told that my first kiddo was breech and that I'd have to have a C-section, I was devastated that like I did something wrong with the baby and that the baby was going to have less than optimal outcomes. Also, sometimes with an emergency section, there's a lot of feelings that moms may have that the delivery didn't go along with their birth plan and it didn't go the way that they thought they would. And these feelings can affect how the mom interacts with her baby and their other family members and her view of herself. And we have the opportunity to educate mothers on how common C-sections are, minimize any possible shame that goes along with that, and improve their physical recovery so that mom can have optimal interactions with her new baby and family. So next, I'm going to go over some system-specific recovery considerations. First, with the respiratory system. A little statistic is maternal morbidity from acute respiratory distress syndrome has increased 205% since 1993. We can help with this by assessing resting and active vital signs and performing interventions as needed, including thoracic mobility, using an abdominal binder post-surgery, splinting with coughing, incentive spirometer, exhalation with effort, energy conservation, work task simplification. We basically want to make sure that they are not scared to move or cough so that they can keep their airways clear after this major abdominal surgery. Some GI system considerations including, early mobility facilitates pre-pregnancy organ function. We want to get them moving, get those organs going again like they were before the surgery. Improved post-surgical bowel motility reduces the risk of post-operative ileus, such as gas-related distension or pain, which if you've ever had that is awful. So I've had that myself. It is not fun at all. Improved circulation to the uterus results in stronger contraction, fundus reduction, and less risk of postpartum hemorrhage. And bowel motility, like being able to have a bowel movement, is important to returning home and can be a source of anxiety for patients in regards to their incision. And then pain medications given during a cesarean section can increase issues with constipation. So providing education on how to manage this can also be very helpful. This can be done through like dietary ways, so making sure they're getting adequate fiber, anti-inflammatory foods, and water intake. Positioning and breathing during those initial bowel movements, using a towel or a pillow to splint over their incision so that they feel like it's better protected. Breathing techniques to minimize breath holding and bearing down. And then like the squatty potty positioning to help allow gravity to get those bowel contents to come out. Some lymphatic system considerations include, we want to reduce edema early on to improve early return to function rather than waiting for it to go down on its own. And this can be done through lower extremity and pelvic floor isometrics and breath work, compression garments such as legging or shorts, or I know I had a pair of bloomers that I wore after my last C-section that I thought were amazing. Positioning is another way. So we want to get the patient flat. A lot of patients after a lower abdominal surgery, they want to stay in a slightly flexed position, such as like reclined or sitting, because that's going to initially feel better on their incision. But this can inhibit lymphatic flow, especially considering that there are large amounts of lymph nodes in the pelvic region. And so helping the patient learn ways to get in and out of supine can help with that lymphatic flow and help minimize overall edema. So I'm going to shift gears here a little bit. I realize that while in the hospital, we may only get a short time to spend with the patient, and there's a lot of information to try and fit in that short amount of time. So another option to replace or in addition to hospital-based rehab can be home health-based rehab. And ideally, this would be completed within that acute time frame or like the 2 weeks postpartum. And ways that we can, or things that we can do with this include assessing the environment and their social life and make recommendations that are really specific to their situation. We can get in their home, we can actually see exactly what things are like instead of just trying to mimic them in the hospital. We can look at their home layout, such as if they have stairs, educating them on placing commonly used objects within reach so that they don't have to be reaching up to grab things or bending down to pick things up, or not running up and down the stairs multiple times a day. We can look at their family support. How much help does the patient have upon returning home? And then educating the family, if available, to help on how to help assist the mother and help with the baby. We can discuss her occupation and how much maternity leave the mom has. For example, if the mom only has 8 weeks if she has to return to work 8 weeks post C-section, and she has to stand or lift for a majority of her day, we can educate her on how to start preparing for this ahead of time so that she's not going from full rest to full activity within a few days time span. We can also assess and monitor wound healing and check for infection. So that way they're not going from lots of eyes on while they're in the hospital to basically 6 weeks before somebody has looked at that incision again. And we can also educate on desensitization work around that incision to help with healing and nerve discomfort and pain and things like that. We can teach patient positions and ways of moving that can help manage intra-abdominal pressure to minimize issues with prolapse, incontinence, pain, and C-section incision issues. And again, we can actually practice it in real time because we are there with the patient in their environment. We can also teach energy conservation. So if they need an assistive device, like a walker or cane, even or OT based things like a peri bottle, a shower chair, and things like that, just to help improve recovery. Separating daily tasks into smaller increments, sitting during meal prep or other tasks that they would normally stand for. And again, bringing frequently used objects to like waist height so they're not having to bend down and lift and pick things up. So all of this education as well that was provided in the hospital can also be done in like the home health setting too. So in conclusion, I feel that PT and OT rehabilitation is necessary in acute care settings in order to provide optimal recovery from cesarean sections.